Thank you very much, Darren. Next up, we've got Mr. Mark Laniado, consultant urologist from Heatherwood and Wexham Park, and he's going to talk about prostate cancer.
Thank you, Simon, from Frimley Health now. Prostate cancer mortality continues to fall faster in the United States and Canada than it does in the UK and Australia. It's fallen to lower levels than it has before PSA screening. And what can we do about that? Well, recently Fritz Schroeder published his updated results of up to 13 years follow-up, and the number of men needed to be invited for screening has reduced from 1,410 to 781, and the number needed to diagnose has reduced from over 40 to 27. 60% of the cancers, though, that were diagnosed were low risk. And the problems of testing for prostate cancer persist. We tend to diagnose low-risk disease. We tend to cause complications when we treat people, and then many men persist with disease that progresses despite screening. In fact, for every 190 men who were saved from dying from prostate cancer, another 355 men died from prostate cancer. So we're clearly not succeeding. So active surveillance, of course, is a method by which we can reduce the problems from overdiagnosis. Larry Klotz published his updated data this year in the Journal of Clinical Oncology, and he showed that at 15 years, there's 94% specific survival from prostate cancer. This is extremely good. It's for men with low risk to intermediate risk disease. But there was a problem. 24% and 36% of men have come off active surveillance, and what can we do about that? And furthermore, men who had Gleason score 3 + 4 = 7 disease were 4 times more likely to die from prostate cancer than men with low risk. So as Larry Klotz says, how can we identify the bad actors before they take part? Well, there have been various innovations from biomarkers, genomics, and multiparametric MRI. There are multiple novel biomarkers. These can be used before a biopsy, after a biopsy to decide if a re-biopsy is required, whether we should treat or monitor people, and they can predict the response to drugs such as enzalutamide and abiraterone. NICE recently published in June this year its assessment of use of biomarkers after a previous negative biopsy, and they looked at the efficacy of biomarkers in conjunction with multiparametric MRI. And if you look on the right, this is a decision curve analysis, and if you see the models that included MRI completely trounced the models that did not include it. MRI was clearly the best way of identifying people who needed repeat biopsy, and biomarkers added no value. What about MRI? We've heard a lot about it today in the poster sessions. There have been many studies published and several meta-analyses this year. In this meta-analysis of over 14 studies, the pool sensitivity was 78%, the pool specificity was 79%, and the negative likelihood ratio is 0.28. MRI is better at identifying high risk than low risk disease, and you can see the sensitivity moves up from 78% to 84%, and the negative likelihood reduces to around 0.21. This means that for many of the studies, the chance of identifying or the chance of missing significant disease was less than 5%. But controversy continues. There is difficulty in learning. It takes a long time to learn. There are differences between readers and within readers. If you ask the same radiologist to report again, they may give you a different result. The different MRI scanners have different efficacy, specifically relating to diffusion. And then what is significant disease? Is it a little bit of pattern 4 significant or not? Indeed, in the active surveillance studies, it probably isn't. And what's the reference standard? Is it a 12-core biopsy? Is it a sector biopsy? Is it 5mm biopsies? And then MRI is not so good at identifying transition zone tumours. Recently, in fact this year, the European Society of Radiologists and the American College of Radiologists had a consensus document on how to report MRI. And this is important because it should allow consistency in reporting and clearer communication with clinicians. MRI-targeted biopsies have been shown to be much more efficient than untargeted biopsies. Pinto and Panibianco published studies, randomized and prospective, looking at the utility of multiparametric MRI-targeted biopsies, and they showed that you could detect 30% more high-grade cancers and 17% fewer lower-risk cancers. And if you use systematic 12-core biopsies in addition to the MRI-targeted biopsies, you'd have to do 200 of these to diagnose one more high-risk cancer. And furthermore, you label there's another 17 men with prostate cancer that is so low risk it doesn't matter. There are problems also with Gleason grading, but this has also been improved. The International Society of Urological Pathologists met in November last year, and they've refined the Gleason grading for pattern 3. It was previously redefined in 2005, but it's recently been done again. The effect of this is to reduce the proportion of patients with Gleason score 6 disease, and so move patients up the Gleason scoring system. To improve our understanding, or specifically to improve our understanding for patients, it's been suggested that we could create grade groups. Now, a grade group goes from 1 to 5, and the lowest grade group is 1, which is Gleason score 6, and the highest grade group is 5. And the thoughts are that if you tell a patient who's got a he's got a grade group 1, he's more likely to accept active surveillance than if you tell him he's got a Gleason score 6 tumour. I've been asked to talk about the National Prostate Cancer Audit. This is incredibly important. It's collecting data and has been doing so since last year, and will soon be collecting data on patient-reported outcomes. It's essential that we all contribute to this. And recently, we've also heard about the STAMP-Chi trial. This is obviously another treatment, another changing publication, and Noel Clark has presented this several times at this meeting. Essentially, for men who have metastatic disease, if they're treated with docetaxel as well as androgen deprivation therapy, the overall survival improves by 22 months. So, in conclusion, there have been many changes this year, many new diagnostic tests. We've had important changes in treatment that have contributed to the benefit of our patients overall. Thank you very much.